There's a new way to screen for cervical cancer with self-collection. People can take a sample of cells from their own vagina to test for HPV. The FDA recently approved this for use in providers' offices. There's no pelvic exam, stirrups, or speculum involved. Research has shown that the results are just as accurate as when samples are collected by a clinician. Self-collection has the potential to expand testing to other healthcare settings and reach underscreened populations. I'm Martha Kempner with the American Sexual Health Association and the National Cervical Cancer Coalition. We recently asked two experts, Barbara Moshitsky and Jennifer Smith, who have been involved in the research around HPV self-collection for many years, to explain this new method to us and how it might help us reach the goal of eliminating cervical cancer. Hello, thank you for joining us. Can you introduce yourself and tell us a little bit about the work you've done around HPV self-collection?
I'm Jennifer Smith, and I'm a professor in the Department of Epidemiology here at UNC Gillings School of Global Public Health. And I've been working on cervical cancer prevention for my entire career. And I've been working most recently on a number of studies, both globally and domestically here in North Carolina. The North Carolina studies are called My Body, My Test.
That's right. My Body, My Test had three parts. What was the first bit of the study that you did?
My Body, My Test 1, which is the first phase of the study, we identified women who hadn't been screened according to schedule using a bunch of flyers in the community, and we mailed women self-collection kits. And we just at that point just determined whether women were able to understand the instructions, whether they were able to return the kits, and they found the process acceptable.
What was in the kits?
In the kits, we had instructions, illustrated simple instructions, mostly pictures that described how a woman could self-collect their sample. And then there also was the sample brush, which is a Viva brush that is a small brush that you can use to collect your own vaginal sample for testing for HPV. And then there was a return envelope, as well as some one-page fact sheets about cervical cancer and why it's important to screen for cervical cancer, because it allows us to prevent the disease.
When people screen for cervical cancer themselves, do they have to go all the way to their cervix?
Self-sampling is not cervical sampling. It is largely vaginal sampling. You will have some cells from the cervix that drop down during collection. So you're going to be picking up some of those cervical cells as well that are exfoliated cells that are dropping down. But basically, you have a small brush, you insert it into your vagina, and you turn it around a total of 5 times or to make sure that you have enough cells. But you're really just pushing until you get resistance. And so you're not all the way up at the cervical os, but you're pushing until you get resistance. And that allows you to get a very viable sample to test for HPV, the virus that causes cervical cancer.
And that was one of the things that you found in your study, right? That the samples were viable. How did you test for that?
Oh, absolutely. Yeah, we have had in all of our My Body, My Test studies, we've tested for HPV, which is, again, the virus that causes cervical cancer. You can test for HPV sequences with either DNA or RNA tests, and those tests can be used to determine whether a given sample has a presence of the virus or not. And again, I think what's important is that if you have the virus, you're at higher risk of current disease or future disease, but it doesn't mean necessarily that you have disease. So the tests are being very sensitive, that they allow you to pick up all of the potential current cases and future risk, but it doesn't mean necessarily that you have HPV, that you have invasive cancer. I think that's very important for individuals to know. And also it's important that to really differentiate HPV from HIV. HPV is not HIV. And so we have that very clearly written on our materials and often we're doing education alongside, as we're doing today, alongside the process of actually asking women to self-collect. I think there's more and more information available on HPV, and there's much more education available in communities on HPV, but I think we often find that's very helpful to include those educational points, talking points in our kits and in our interventions.
So you've been doing this for a lot of years. Have you found over the course of those years that knowledge about HPV is going up and that people are, less likely to confuse it with HIV and more likely to understand the connection between HPV and cervical cancer?
That's a difficult question because I don't have explicit data on this and I'm an epidemiologist. So I would say in general, I think we really do need more education, like the education that HPV is very, very common. There are roughly a dozen types that cause invasive cancer. And that if you have one of these high risk dozen types that cause cancer, there's a high probability that your body will actually fight off the infection on its own. But for the smaller proportion of individuals who cannot clear their infections, they're at a much higher risk of developing high-grade lesions or invasive cancer. And that's why it's really important to vaccinate young girls and boys and screen older women so we can actually prevent this cancer. This is a cancer that we can eliminate, we can prevent through vaccination and screening. And so I think, all of these studies I've been doing on My Body, My Test are really to increase access to screening, because we know that individuals who have not been screened regularly or at all, on time or at all, are at much higher risk of invasive disease. And so we really want to close that gap. And this is an access issue. So trying to bring the test, My Body, My Test, women have control of their tests and over their bodies, and trying to be able to have increased access. So mailing kits to women's homes to increase access to screening, I think is really helpful.
Back to your study for a second, you said there were 3 parts. What were the other findings? You said you found that they were able to do it easily and that the tests were accurate. Were there other findings?
The first phase, we found out that it was acceptable and women would actually return their kit, and that the test itself was valid. The second phase on My Body, My Test 2, we had women actually do self-collection at the home and then come the next day to the clinic and do clinic collection with a provider pelvic examination to obtain a cervical sample. And we found there that there was a very high correlation with the self-collection and the provider collection samples, that the vaginal and the cervical samples were highly correlated. But most importantly, when women then proceeded on to get a further examination, we found that all of the self-collected results at the home were able to locate all of the high-grade lesions in the clinic, which I think was really important. And again, this was a very small study. We have very large studies in Europe. I think it's important to note that national programs in Europe are moving towards self-collection. Some of them are focused on underscreened populations, again, these populations of women who don't go into regular clinic visits, and others of them are moving on with self-collection provision in a national program. And so that's our second phase. Then the most recent phase, Martha, we actually did a randomized control trial where we randomized individuals to, basically these are underscreened individuals from low income households. And these are women who have not been screened on time. And so our goal is really to try to identify women who are not screened on time and then provide them with options to increase their screening uptake and follow through so that we can reduce mortality. And I think that's the real primary goal. So if we identify these women who haven't been screened, we want to really try to figure out how to get them screened. So one of the arms was to provide these women who hadn't been screened with an opportunity to have a scheduling appointment. So they could come in and have someone help them schedule their appointment. And in the intervention arm, we had all of them get their scheduling appointment. And in addition to that, we also mailed them a home self-test kit so they could actually have the kit in their hands and remind themselves of the importance of screening. And we found in that trial that providing the self-collection kit to someone's home did increase the screening completion. And those results were published in Lancet Public Health recently. I think, again, the real driving force is to have a woman who hasn't been screened re-engage in screening. I think one of the challenges of self-collection is that, particularly if it's home-based, we want to really ensure that all of the women are going to follow through and get their results. And so I think that's, an issue that we need to really focus on for future research, is how do we optimize if a patient has a positive self-collection result, that she is going to go through the next phase of screening, which involves in-clinic screening, in order to ensure that she gets through the cascade and goes through the secondary confirmation screening and then on to treatment if that's indicated.
You're talking about sending kits to people's homes, but what the FDA approved right now is not a home-based test. Can you explain that to us?
Exactly, Martha. The current FDA approval for self-collection is in a clinic-based situation, not home-based. This can include either self-collection provision in a clinic or in a pharmacy or associated clinic type of setting. And so I think the next step, which is what the National Cancer Institute is working with the FDA to envision, is this last mile research initiative, research study, in which they are actually envisioning potential future approval from the FDA for self-collection at the home. But currently, it is providing self-collection in a clinical setting. And so that's where we are now.
If you still have to go into the doctor's office, right, to a provider's office, what's the benefits of this from a patient's perspective and from a provider's perspective?
I think I'll start with the program perspective, because if you think about a client coming into a clinic and if they choose to do self-collection, there'll be less work from the provider perspective because they don't have to do a pelvic examination in order to collect a cervical sample like you do in your regular primary screening situation or co-testing situation when you're doing primary plus cytology. So in the cases of self-collection, it will cut down, I think, on providers' workload in terms of not having to do that pelvic exam. I think from the client's perspective, self-collection can be a very positive thing because you don't have to have that on the initial screen of pelvic examination. But there are some trade-offs. So I think, for example, we don't know exactly what the guidelines will come out with intervals between testing right now. There's two sets of national screening guidelines that are in draft form, and those have not been finalized, and it's unclear whether there will be it's possible that there's going to be a shorter interval between screening for self-collection than for provider collection, but that is currently unknown. So there may be, if a patient goes in to get self-collection, she might have to have it on more frequent intervals. I think the biggest difference from a patient perspective is that if you decide that you want to do self-collection, you're going to have to, if you get a positive result, then come back and get a provider collection. And that requires an additional visit on your part. So you may decide, if you're already at the clinic, that going ahead and getting your provider collected cervical examination, as you've always done, might be a little easier thing for you to do logistically. So I think that there's some trade-offs. And I do think, though, that if you look at the real opportunity for self-collection, in my view, it's really among the underscreened, trying to get that access point to the underscreened. Particularly, there are women who may be very reluctant to have a pelvic exam. There may be many clinics across the country who have not been able to get these women screened because they are reluctant to get a pelvic exam. And I think their self-collection has a real clear benefit and potential to help increase screening rates. And I'm hoping that that's going to happen as self-collection's introduced, is that if clinics are able to kind of really make sure that those patients who, for some reason or another, don't ever show up for their pelvic examination or refuse to show up or don't answer those requests, that maybe that by offering them the second option of self-collection, that there'll be an opportunity for clinics to really, and providers to really give the care that patients need, which is screening. I mean, screening is a preventative measure that really saves lives. And so I think that's really the opportunity of self-collection. If we can ensure that the women who are not being screened are going to be getting screened, that I think is really where we're going to have the biggest impact, rather than just switching from patients who are already getting screened. I think trying to focus on those higher risk patient population who haven't been screened is a real promise of self-collection.
So it seems like one of the things that's going to be a benefit of self-collection, even while we're limited to providers' offices, would be that other providers could offer this, right? So I could maybe go to my primary care doctor and be screened, or maybe an urgent care. Is that one of the things that, from a public health perspective, people are looking forward to with self-collection?
Yeah, absolutely. And I can't speak for provider practices, but absolutely. I think if you are a primary care practice in an area where you find it difficult logistically to train providers to conduct pelvic examinations, and there may be a dearth of providers, and even in our state of North Carolina, a dearth of providers in certain counties, that could be a real opportunity for you to increase screening rates among your population. And again, I think I'm hoping that if not in that particular circumstance, in order to increase screening rates among the underscreened, that providers' offices will decide that, hey, this is something that we want to do. Again, I think that it does require, though, collaborations for referral, that it's not just let's do self-collection and then tell the patient she has a positive result and good luck finding the next stop. I think there we have to be really vigilant that provider practices are going to have to get into the practice of referrals and knowing where to refer people to in order to ensure, again, the follow-up of the cascade. And this is for any clinical practice point. So certainly practices are very aware of all of these issues. I just think that when it come down to our research, it's been a big learning that, providing a new technology really cannot just be done in a silo. It has to be integrated with an existing care delivery systems. And I think that's something that has been really educational in terms of ensuring that all patients, again, are screened and followed up.
I wanted to ask you, some of your research has been international, and we're mostly talking about the United States in this podcast, but this has really big implications for improving screening globally, right?
Oh, absolutely. I mean, there is just a very different scenario globally. I mean, we do, as I mentioned earlier in the US, we have areas we really have a dearth of OBGYNs to provide pelvic examinations. And I think that's a real opportunity for self-collection. But globally, that issue is magnified. And so I think that there is just such low screening rates. For example, I gave a talk a few weeks ago, and if you even look at the current data of ever screened percentages in many areas of sub-Saharan Africa, we're at a little over 10%. So you're saying that 90% of an eligible female patient population in many countries has never been screened once in a lifetime. And this is far from the WHO goals for cervical cancer elimination, which is calling for 90% vaccination of young girls, 70% screening 2 times in a woman's life, and 90% follow-up from the positive result to treatment. So again, I think we are at, roughly 10%. We need to get all the way up to 70%, and hopefully in the future, even up to 90%. That I think that self-collection is going to be the only way that we're going to be able to do that in global settings. And again, I think it's really important to underline the sensitivity of self-collection is quite comparable to that of a provider collection when you use a highly sensitive assay for detection.
So, shifting back to the United States for a second, you've been working on this for so long. Were you really excited when the FDA finally approved self-collection in this country?
Absolutely. And actually, I thought that it would take a little longer than it has to get this done. So this is, I think, a fabulous opportunity, again, to offer women choices for screening. And again, I think it's important, though, as every new technology comes in, to look at it, not only its benefits, but also potential disadvantages, as we've discussed, and then trying to make sure that all of the processes are well integrated with the existing system to make it as user-friendly to the client as possible. But absolutely, I think it's a great thing that we're having other options. And again, I think if you look at the data, we've had a number of discussions at a number of the global international conferences, and you hear some of the data coming out of, in particularly the Netherlands, and they are not currently seeing, and maybe we'll see it in Australia soon. I think a publication's around the corner, but they're not currently seeing an increase in screening uptake among the underscreened with a self-collection introduction. And I think that needs to be really like the top of our minds is how can this new technology, again, really increase screening rates among those women who are not undergoing pelvics? Because if we just have it be a switching from a pelvic to a self-collection, we're not going to really make an impact on mortality if we are really knowing that most of the mortality is among those patients who've not been screened regularly or at all. So again, I think a call for programs and providers to really consider this option of self-collection in your programs, particularly for these individuals who've not been screened on schedule or at all. I think it's a real opportunity, and it may be ultimately more acceptable to patients to do their own self-collection for a number of reasons, as compared to a cervical one.
So you brought up Australia, and one of the interesting things about Australia is their program to vaccinate girls and boys to widespread vaccination, which we don't necessarily have here. Have you, in your research in HPV, been exposed to the kind of negative messaging about the HPV vaccine that is getting in our way?
I think that it is really important that in anything that we do, whether it's, a screening intervention or a vaccination intervention, that involves, community decision making, that we really understand how communities think, and we really take the time to make all of our messaging and our materials consistent with that understanding. And so I do think that our rates are actually quite good in the US, given that we don't have a national vaccination program. I think Australia, as you said, is just the golden apple, I think, and many European countries as well in terms of systems to provide vaccination. And the European data is also very strong. Australia was the first country that really gave us the data to actually prove that vaccination does reduce the incidence of invasive cancer, which I think was really, really good. But I do think that we're making a lot of headway. I think that, if we don't have HPV vaccination kind of on its own, I think as a part of an adolescent platform, I think that helps with acceptability as well.
So is there something you would say to somebody who was maybe skeptical about getting the vaccine or who didn't know about the vaccine if if they had a child who was 9 or 11?
Yeah, I mean, I think I'd say that, HPV is a primary cause of cervical cancer, and you may know that already, but what you might not know is HPV causes other cancers, vaginal, vulvar cancers, oral cancer, and these are cancers that we actually can't screen for in the future. And so, if you in penile cancer, anal cancer among females and male. And so I think, we know that there's very good screening programs for cervical cancer. And if you're vigilant with your screening, you shouldn't be getting invasive cancer. For these other cancers that are HPV associated, the vaccine really is a promise. I mean, if you had a brother who almost died of HPV associated oral cancer, wouldn't you have wanted to vaccinate your child? And I think that that is because these HPV causes these other cancers, again, vaginal, vulvar, oral, anal cancers among men and women, and then penile cancer among men. And we aren't able to screen for these, then I think it's a really good argument for vaccination. And it's very safe. It's very safe, and it's been given to millions of people globally. So I think we're no longer in a situation where it's a new vaccine. I think this is a proven vaccine. It protects against cervical cancer, which is a horrendous disease, and as well as these other HPV associated cancers, which, individuals die of these. This is one vaccine that you can give that will prevent a virus that causes cancer. Why wouldn't you?
Is there anything else you feel like you didn't say?
Yeah, I think that cervical cancer is really a cancer that we can think about elimination. And I think that's a big term, but I think there's huge promise if we can increase screening rates and increase the follow-up of those who have positive screen results and also increase vaccination rates on a nationally, we could make a really big impact, not only on HPV associated cervical cancer, but also HPV associated cancers that are non-cervix, as we've discussed. And I really want to thank you, Martha, and your ASHA team for inviting me to speak today. I want to wish everyone a very, very happy January. January is cervical cancer free month. And again, thank you again.
Thank you so much for joining us. This was very helpful.
Wonderful. Thank you.
Thank you so much for listening. If you'd like to learn more about HPV screening with self-collection, visit the NCCC website at nccc-online.org.